Assalamu alaikum. Acute vocal folds hemorrhage. What can we do when the voice, particularly of a professional voice user, is suddenly lost, usually during a performance, and he presents with this alarming laryngeal appearance? The acute hemorrhage is caused by ruptures of capillaries that travel through the superficial layer of the lamina propria of the vocal fold. The inciting factor is typically phonotrauma, but can also be caused by mechanical stress such as coughing, for example. The blood would then diffuse through the superficial layer of the lamina propria, which has very low resistance to the diffusion of the fluid, and this would increase the vocal fold mass and also the stiffness because of the different properties of the escaping blood from the fluid in the lamina propria. The combined effect of increasing mass and stiffness would alter the pattern of vocal fold vibration and cause sudden dysphonia. The appearance is striking and can cause significant concern to professional voice users. The blood vessels on the surface of the vocal folds in the lamina propria approaches the center of the vocal fold from anterior and from posterior. The middle part has less diameter of vessels than the anterior and the posterior part. These vessels would run parallel to the vocal fold edges in the healthy subjects. You can see this clearly in the narrowband imaging, which shows the blood vessels much more clearer than the white light. This arrangement of parallel blood vessels to the edge of the vocal fold protects the blood vessels from the shearing effect of high-frequency phonation. This can produce various disorders in blood vessels if they're running perpendicular rather than parallel to the vocal fold edges. Also, you can see that the vocal folds are a little bit tortuous, and this is to allow for stretching of the blood vessels when the vocal fold changes its length during phonation, producing high frequencies, for example. These two features, the parallel arrangement and the tortuosity of the blood vessels, optimizes the mucosal wave of the vocal fold, providing flexibility during shearing effects during phonation. The microcirculation of the capillaries in the superficial part of the lamina propria is also well adapted to withstand stress. The vessels that course in the longitudinal direction parallel to the vocal fold edge also don't anastomose with vessels coming out from the deeper layer of the vocal folds. And these vessels, the endothelial cells, are surrounded by a cushion of extensive concentric lamella from the basement membrane, and also they are reinforced with some filaments, intracellular filaments, to protect against high mechanical vessel wall stress. Even then, the phonatory vibration can produce sometimes forces sufficient to tear these fragile capillaries, resulting in bleeding within the superficial layer of the lamina propria. And of course, if there are abnormal blood vessels on the surface of the vocal folds, like a varix or an abnormally dilated blood vessel, this can make these segments of blood vessels more vulnerable to rupture and produce a hemorrhage. The examination will show the different forms of the vascular lesions and would be helpful in taking the therapeutic decisions. Here, for example, you see a small ectasia that becomes more prominent during singing, and this may require a laser. Here you could see a more prominent varix and some ectasia on the other side, and this becomes much more prominent during the menstrual cycle and can be treated by hormones therapy. Here you could see multiple branching of the blood vessels, multiple dilated, but without formation of the varix, and these can be treated with voice therapy and voice hygiene. Here you could see vessels going away from a central point in both directions with various branching These would usually be associated with a lesion somewhere here. It can be a small sulcus vocalis or a mucosal bridge that requires examination under anesthesia, or you can see a small vascular polyp in here that requires not only excision but also lasing of the feeding vessel. And then other forms of abnormalities were added, including the convoluted vessels of the vocal fold, which describes an advanced stage of the varix with a very prominent, organized, and deformed blood vessel on the surface of the vocal fold. Acute vocal fold hemorrhage is not common. It accounts for about 1.4% of voice problems of new cases in voice clinics. The age can be anywhere between 20 years and 70 plus years, but usually it is somewhere between 36 and 42 years. And there is no significant differences between the incidence in females and in males. But it affects professional voice users in more than 50% of the new cases, and about a quarter of the patients would actually present with a recurrence of the hemorrhage. The etiology and the risk factors. Phonotrauma comes as number one of the list, usually during singing or high demand performance like teaching, or voice abuse or coughing. And also medications including anticoagulants and non-steroidal anti-inflammatory drugs, and some systemic conditions like bleeding disorders. A positive correlation has been established between the hemorrhage and the use of anticoagulants or a recent upper respiratory tract infection or acute vocal trauma during a performance. Other factors such as recent surgery, smoking, and even hormonal changes in females, although this is only based on observational studies. Predisposing factors include viral illness, laryngitis, including laryngopharyngeal reflux, and pre-existing vascular ectasia or during menstrual cycle. The main risk factor for hemorrhage in the vocal fold is having a varicosity in the superficial layer of the lamina propria. If a patient has a varix, then he is 10 times more likely to have a hemorrhage than those who don't have a varix. This was shown by the hazard regression analysis. But although the rate of hemorrhage is significantly higher in patients with varix, the overall incidence is still quite low. Several other factors were also investigated to see if they pose a certain risk for vocal fold hemorrhage. Among these are the factors that decrease phonatory efficiency. Things like benign mucosal lesions, a cyst or a pseudocyst or a polyp, or even vocal fold varices. These factors may decrease the phonatory efficiency and increase the phonotraumatic stress. However, these factors were not shown to have any association with vocal fold hemorrhage more than the normal or the average. We would expect the vocal fold hemorrhage site to be at the maximum mechanical stress from mucosal displacement during the vibration. Two such sites are either the most lateral part of the vocal fold, as suggested by Hochman, who suggested that the mucosal wave at this area would decelerate quickly and then reverse back to start the closing phase of the phonatory cycle, or the edge, the vibrating edge of the vocal fold, where you would expect the maximum traumatic forces augmented by collision between the two vocal folds. In reality, there were no correlation between the site of the hemorrhage and cases. There were also no correlation between the site of the varix and the site of the hemorrhage, and there was no correlation between the shape of the varix or the ectatic vessel and the site of the hemorrhage. The common clinical presentation is sudden voice loss, usually with certain amount of voice roughness. Almost all patients would present with this. May also describe voice fatigue and throat clearing. a good percentage of the patients would have a concomitant lesion. Almost 3/4 would have a concomitant lesion in the vocal folds, ranging from benign mucosal lesions to things like either a mucosal bridge or a sulcus vocalis. The most common of these lesions would be a hemorrhagic polyp, and about a third of the patient would have a varices, a varicosity, usually on the same site of the bleeding. The voice performer, particularly singers, would usually know exactly the point at which they have lost their voice and would know how to request urgent consultation for this. If they stop using their voice at the initial stage, they may have a bleed under the surface of the epithelium in the superficial layer of the lamina propria. But if they continue despite feeling the sudden loss, if they still give the effort to phonate, they may end up with a large hematoma in the vocal fold. In addition to the effect of mass loading into the vocal fold, if the elastic properties of the mass is different from the surrounding tissue, like for example in a submucosal hemorrhage or a fusiform polyp, then the loaded mass on the vocal fold would also have different physical properties in different areas, and this would lead to increased stiffness of the vocal cord in addition to the effect of the mass loading. This would again require a higher driving subglottic pressure to drive the vocal folds into oscillation and would lead to a phase lag between the two vocal folds during the oscillations. But the main value of stroboscopy in cases of acute vocal fold hemorrhage is to differentiate between two types of patients. The milder type would be just a blush of red hue under the surface of the vocal fold due to capillary leak. And the other type is a hematoma that can be extensive due to collection of blood in the lamina propria. In the milder type, this can be expected to resolve quickly with some voice rest, relative voice rest, which would mean abstinence from loud and prolonged speaking. Whereas if there is a mass loading and hematoma formation, then the patient would require strict voice rest, absolute voice rest, so as not to extend the size of the hematoma, and it would usually take much longer to resolve than the milder. Differential diagnosis would include things like vocal fold pseudocyst, or a hemorrhagic vocal fold polyp, or even erythroplakia with new blood vessel formation, usually horizontal rather than vertical in direction, or vocal fold varix, or other forms of abnormal blood vessels, including ectatic blood vessels, or even mild vocal fold varices. The management of acute vocal fold hemorrhage is essentially conservative, apart from few indications for surgical intervention for selected cases. The main line of treatment is voice rest for at least a week that can be extended further if needed. This is particularly important for professional voice users and patients who also have an associated mucosal pathology in their vocal folds, together with vocal hygiene education. Medical treatment is essentially reflux management if indicated, and to stop the use of anticoagulant medication if that is possible, and avoid non-steroidal anti-inflammatory drugs. And in certain patients, an oral steroid course can be used with precautions, but this is not universally accepted, and good hydration. Surgical intervention would be considered in few selected cases. This would include those patients with massive subepithelial hematoma. In these cases, you may consider doing a lateral chordotomy and evacuation of the hematoma, or patients who have a varix or other vascular lesions of the vocal folds, in whom photoangiolytic lasers, coagulation, or vaporization may be considered. or if the vascular lesion on the vocal fold is at the vibrating margin or the undersurface, you may consider doing a microsurgery and microflap with resection of the offending vessel. The indications for surgical intervention in selected cases of acute vocal fold hemorrhage include patients who have recurrence of the hemorrhage more than a single episode, or a single episode of hemorrhage if the patient have a varix or other abnormal blood vessel on the vocal fold, or if he has a hemorrhage and an associated mass such as a cyst or a polyp that require microsurgery, or in the very rare cases where evacuation of an extensive vocal fold hematoma is required. In the mild cases of hemorrhage, which is more common, the subepithelial hemorrhage will just cause a discoloration of the vocal fold with no evidence of significant mass loading. In such cases, under stroboscopic guidance, if there is adequate vocal fold mucosal wave pliability, the management would be a relative voice rest with avoidance of shouting or loud voice or prolonged voice, and this brief relative voice rest with avoidance of blood thinners and the use of steroids in some cases would be all that is required. But laser therapy is now the preferred treatment modality, again through a microlaryngoscopy approach. Carbon dioxide laser was initially used in the defocused mode with brief pulsing mode and low power setting, 1 to 2 watts. This is used to coagulate an offending vessel like a varix or an ectasia at 2 or 3 different spots along its length. This may be now superseded by photoangiolytic lasers like the pulse dye laser or the KTP. They can be sometimes used in an outpatient setting, and they are used to obliterate the vessels without surgical intervention, targeting the hemoglobin in the vessel's tissues, and this is usually quite effective. The KTP 532 laser can be used for photocoagulation of small vascular lesions because the laser beam will be very well absorbed by the hemoglobin and the damage to the epithelium is minimum. It can be used in a low power setting of 1 to 2 watts in a continuous mode with 0.4 to 0.6 millimeter beam for 3 to 7 seconds, delivering a total of 3 to 7 joules. It's not recommended to use the KTP for things like a hemorrhagic polyp or a hematoma after a subepithelial vocal fold hemorrhage, because these lesions would require a higher doses and can cause more scarring because there is little blood flow inside, and the photocoagulation is either impossible or requires too much laser energy. These lesions, the vascular polyps or the subepithelial hematoma, are better treated by open surgery resection. But the KTP laser is cost effective and time saving and can provide excellent results compared with other modalities. It is interesting to note the results of a survey conducted on the members of the American Association of Broncho-Esophageal Association. They showed that the members would usually intervene surgically on a vocal fold with a varix or an ectatic vessel following a single episode in about 33% of the cases, but about 55% of them would require 2 episodes of hemorrhage plus the varix in order to indicate surgery. They use angiolytic lasers like KTP, mostly in the operating room, but also in an office setting. And they have noted that their cases of vocal fold hemorrhage sometimes evolve to become a vocal fold scar in a small percentage of the cases, less than 10%, or it may form a hemorrhagic polyp in about 18% of the cases. The members of the American Association recommend the use of a stroboscope to guide the decision to get back to gradual voice use based on the stroboscopic evidence of resorption of the subepithelial blood and the return of the normal mucosal pliability. The angiolytic lasers are the preferred surgical intervention technique for most cases of abnormal blood vessels on the vocal fold, including varices or ectasia, particularly if the abnormal blood vessels are on the surface of the superior part of the vocal fold. But when the abnormal varices or ectasia are actually on the margin, the vibrating margin of the vocal fold, it's preferable to use microlapharosurgery resection of the offending vessel to avoid any collateral damage to the vibrating margin of the vocal fold together with stiffness. Surgical intervention, again in the form of resection of the offending vessel, may also be considered if the offending vessel may leave around a mass-like structure even after the use of laser ablation. Operative resection would entail a good exposure to the vocal folds, and once the lesion is identified, a mini flap can be raised by incising just lateral to the vocal fold abnormality, just lateral to it. You have 2 or 3 millimeters in length. A micro flap would be raised, followed by using of a hook or a fine needle to dissect the vascular abnormality from the lamina propria and resecting the lesion with minimal loss of the epithelium and minimum disruption to the lamina propria. The prognosis of vocal fold hemorrhage is generally favorable with early management with voice rest, but there are certain risks, the most important of which is a recurrent hemorrhage. This would be expected in about a fourth of the patient, that they may have a second episode of bleeding. There may be also the risk of scarring and vocal fold stiffness, but this may not have a bearing on the voice or the objective voice parameters assessed. It was noted that a significantly larger number of patients who had a vocal fold hemorrhage, particularly if they are professional voice users like singers, were miss more work days due to a voice problem in the year or two following the bleeding episode. Analysis of the prognosis of vocal fold hemorrhage after the first month of the bleed had confirmed good early recovery. All patients were managed with voice rest and showed improvement in the first follow-up visit after a mean of 12 days, a range of between 6 and 30 days. They showed this improvement subjectively and also in their vocal function tests, and the vocal function test VH110 showed good recovery indications, and the same with video stroboscopy had also showed resolution in about 2/3 of the cases within the first month. So generally speaking, the impact of the vocal fold hemorrhage appears to be limited to the acute stage and have no long-term significant or severe voice abnormalities. About a fourth of the patients with vocal fold hemorrhage will have a recurrence. The average time to the first recurrence was about 5 months, with a range between 6 days and about 2 years. The presence of a vocal fold varix or other abnormal blood vessel significantly increases the risk of the recurrent hemorrhage. About half of the patients who have a varix and a previous episode of vocal fold hemorrhage would have a recurrence. This is 12-fold greater than patients who had a previous hemorrhage without a varix. No other factors were significantly associated with the recurrence. These factors include the gender, whether they are professional voice users or not, the extent of the initial hemorrhage, whether mild or severe, or the presence of other mucosal lesions like a polyp or a cyst, or a vocal fold varices. All these factors were not significantly associated with recurrence. The main factor is a presence of varices. And a multivariate logistic regression had confirmed this, that only the presence of a varix is associated significantly with a recurrence. It's a very significant correlation. No other factors would be associated significantly with a recurrence apart from the presence of a varix, which raises the possibility of the bleeding of a recurrence to about 48%. By this, we come to the end of this presentation on acute vocal fold hemorrhage. Assalamu alaikum.